Specialist here at the Maine Health Management Coalition, and we're pleased this afternoon to present you with Maine's Value-Based Insurance Design 101 as our webcast today. I will begin with a little overview about the coalition for anybody listening that is not familiar with us, and some upcoming dates for you to be aware of. Just be advised that at any time during the presentation, we encourage you to type questions into the chat box. We will present them to the presenter at the end of the presentation for her to answer for you. Also, this is being recorded and will be available on our website at mehmc.org, so you can access this presentation at a later date or share it with others. The Maine Health Management Coalition is a purchaser-led partnership among multiple stakeholders working collaboratively to improve health and maximize the value of healthcare services for the employees and dependents of Maine Health Management Coalition members and all the residents of the state of Maine. Being a multi-stakeholder group comprised of over 60 members, we include purchasers, health plans, brokers, benefit consultants, providers, affiliates, and consumers all working together to make the changes and improvements that we aim for in increasing the value of healthcare in the state. We accomplish this through several initiatives, but everything is founded on our data department, who has an all-payer claims database with important information to help guide us. One of our initiatives is based on transparency and public reporting. We publicly report outcomes, safety, patient experience, and cost ratings on our consumer website, Get Better Maine. We engage consumers, employees, and communities in their role in system and care improvement, including personal responsibility for health, choosing quality, and appropriate utilization of services. Today's topic, benefit design, is what we're covering. In this initiative, we identify key patient and provider benefit and reimbursement incentives, such as value-based insurance design, that reward the use of coordinated, appropriate, high-quality, patient-centered care. And the final initiative we employ to reach our goals is through payment reform. So we explore alternative payment arrangements with providers, hospitals, and systems, and align those arrangements with the coalition's goals for high-quality, patient-centered care at a reasonable cost. I want to make you aware of some upcoming webcasts that we have. The first one in April is already open for registration. That one is about mental health in the workplace, prevention, early intervention, and employee assistance programs. We have a great lineup of expert panelists and speakers for that. As you can see on the bottom of the screen, you can sign up to receive webcast alerts for when registration is open just by going to our homepage on mehmc.org. In May, we will be covering integrating behavioral risk, safety, wellness, and occupational medicine. And in June, we are putting together a lineup of speakers to present on patient-employee engagement resources. Please also be advised that webcasts are free to all our members, although we do charge for some webcasts to non-members, and we also offer some continuing education credit for some of our webcasts. We also want to alert you, and please save the date for the Maine Health Management Coalition's annual symposium, which is confirmed for September 16th in Portland. I hope you can join us. And coming up very soon, we will be celebrating the culmination of a year in our CEO Champions Wellness Program, where CEOs compete for the best wellness program, and that will be presented at the Wellness Council of Maine's annual meeting, April 7th, 8 to 3:30 in Portland. You can also get involved with the coalition through joining or sitting in on any of our work groups or committees, reading or asking to receive our wellness and member newsletters, inquiring about VBID training in addition to today's presentation, And also be aware that we do provide training for policymakers on evidence-based medical policy. Here's a slide just showing our current membership, which is also available on our website. So you can check that out at any time at your leisure. And I just invite you to join us. The more people and stakeholders we have involved, the stronger we are. So contact me, Marie Stuckey, at 844-8106, extension 227, or at my email listed on the screen. And now I am pleased to present Nancy Morris, today's speaker. Nancy R. Morris has been the Communications Director for the Maine Health Management Coalition since late 2009. This is a role she was destined to play given her extensive knowledge of Maine's healthcare quality improvement efforts, employee benefits, and communications. Prior to her role at the Coalition, she helped HealthSource Maine become the largest HMO in the state and helped clinicians in northern Maine become some of the highest scoring providers on the Maine Health Management Coalition's consumer website. With the able assistance of Robin Allen, the Coalition's full-time VBID manager, and interested parties both inside and outside Maine, Nancy is helping to build a new template for how health plan design can strengthen and support other healthcare reform efforts related to patient engagement, payment reform, and healthcare improvement, offering providers administrative relief and patient and plan sponsors better health at a more reasonable cost. Now, here to tell you all about this program is Nancy Morris.
Hello, everyone, and thank you for attending today's session. I'm excited to share with you the efforts of so many individuals and organizations in Maine and beyond that have been working with us to develop a common sense benefit delivery platform aimed at thoughtfully aligning the efforts of all entities working to improve health in our state. There's no doubt that the Coalition's efforts have been enhanced by many experiences and insights of our VBID committee members. We value their participation, and we invite you to consider joining our network. Let's begin by talking about what exactly value-based insurance design is. As you can see, we have an explanation of what it is here, an insurance design that aims to increase healthcare quality and decrease costs by using financial incentives to promote high-quality, cost-efficient healthcare services and consumer choice. In short, we're looking at high-value benefits and providers and making sure they're favored through the plan design. And that's important because not all services are created equal. As this chart shows, only 37% of services have robust data supporting their use. And so we are favoring, under our plan design, those 37% of services because we believe that they can lead to either higher outcomes or decrease the need for more intensive services later down the line. And in a few minutes, I'll explain exactly why we're doing this. So why would we ever get into plan design? It's not anything the Coalition hopes to sell, but rather what this is an attempt for us to aid people who are trying to reduce healthcare costs while raising quality in the state of Maine. As you can see in the photo here, Angus King helped us gather together CEOs from both hospitals and major employers in the state of Maine several years ago. And that group told us that we need to develop and offer a benefit plan that supports evidence-based care and that allows us to move to outcomes-based performance. Many of the hospital CEOs told us that the benefit design often impedes their ability to provide high-quality, low-cost plans, low-cost services, and so therefore they asked us to redesign a plan so that it makes more sense and then encourage employers to begin offering that plan. So that's the work that we've been doing inside the Maine Health Management Coalition through the help of the State Innovation Model Award. So we began by looking at what kind of services would we need to pull out of the benefit design, and we were lucky to see this information from the Institute of Medicine Healthcare Imperative Study that basically told us that 30% of services in the current healthcare program is wasted services. And so through this benefit design, you will see how we have tried to make sure that we eliminate unnecessary services, excessive administrative costs, inefficient delivered services, missed preventive opportunities, and prices that are too high. So let's take a look now at the benefit design. You see those arrows running across the chart. That's because this is a bit of a fishbone diagram. We began by looking at what most people consider value-based insurance design, which was favoring high-value services. But we felt that if we just worked on high-value services, we would potentially not be as impactful as then we would be if we took a more robust approach and made sure that we were making sure that patients were going to high-quality providers and that those high-quality providers had time to spend with their patients, and then that those patients were encouraged to follow the evidence-based treatment protocols their doctor had recommended, and that we also wanted to make sure that we didn't see all our work eaten away by administrative expenses. So we also have a VBID administrative committee that's working on reducing those services. So now let's take a closer look at all the components of the plan. The first one is the benefit design itself. And again, as you may recall, I just said that 37% of services have robust evidence that they can have a significant impact in either arresting a patient's condition or preventing the need for more expensive services down the line. And unfortunately, on many health plans now, these services aren't always covered as robustly as we think they need to be more effective. And so under our plan, we are now testing with consumers this idea of having 3 levels of services. The first being green, which are evidence-based. The second set, which are yellow or preference sensitive. And the reason why we made them green and yellow is because we wanted those green services to be a message to patients to go and get these services. We've heard anecdotally from many doctors that they're spending a lot of time trying to convince patients who have high deductible plans to get high return evidence-based services, and we want to help get patients in for those high value services, and so we wanted to code those services as green services under our benefit plan. The next set of services are also evidence-based, but those services are one of several ways a patient could potentially either prevent an illness or arrest a condition. And so under this plan design, we want to encourage both the patient and the doctor to slow down and take a look at the options and let the patient pick the option that makes most sense for them. And we think this is very important because we know that when patients are involved in the decision making, that they are more likely to follow through on the service. And we know that just making these services affordable is not enough, that we have to sell patients on getting these services. And so by having more than one option revealed to patients with the pros and cons, we believe that patients are more likely to pick a service that makes more sense for them and follow through in getting those services. So those yellow services, again, are also evidence-based and would be covered at the highest level under this plan. The red services are the services that have the least amount of evidence or have evidence that they are sometimes overused. And under this scenario, we'll want patients to make a hard stop and consult with their doctor to make sure that that service really makes sense for them, or learn if there are other options that they can do, or if waiting to see if the problem accelerates is a appropriate strategy at that juncture. So that's the first set of services under the value-based insurance plan. And this next slide will again reiterate what we're trying to achieve, give messaging to patients and to doctors, clear signals that a green service has a high return on investment. A yellow service means that there are several paths that a patient could take, and so they need to slow down and review their options and select the plan that makes most sense for them. And then the red services are those services that are services that have the least amount of evidence, so that patients need to stop at that point, consult with their doctors, and decide if they want to follow through. Under this benefit design, this is where the high deductible would kick in, and patients would be responsible for paying for a share of this service up until their out-of-pocket maximum. So this is what we hope, this is an example of some of the information that we hope to give patients at the time of service. We are very interested in giving patients both the cost and the efficacy of the different options that are being offered to them. As you can see, the service is shown in green. Patients are given information about the benefits and the risks of services, and then also information about exactly what it would cost them under their health plan and what is the average price in the community. We are currently running focus groups in Bangor and in Portland to test this with consumers, so we are likely to change it up a bit, but I hope you get the idea. We also hope to put this information in a portal with patients, and along with the corresponding meta-analysis that helped us decide to make this service a green service, so that patients can review it at a later point in time, and also that they can share it with other interested parties who they wish to share it with. The next set of services are those yellow services, the services that are also evidence-based, but where an option is available for patients and how they want to address the issue that has been diagnosed by their doctor. Again, what we want to do is share this information. Again, we are testing this, and it may look a little bit differently when we're completed, but we are very interested in promoting shared decision-making through this program, and we know that right now HealthWise makes available through 13 electronic medical record vendors a shared decision-making program, and we want to, again, have this information embedded in the EMR. We're not sure who's the right person to go over this information, but we do think it's important that patients know when they have options, because, again, we think we're going to get higher buy-in for these high-value services. The last set of services under this plan are those red services, and those are the services with the least amount of evidence or more harms than potential goods. And so under this program, again, patients would be told both the benefits and the risks, and then exactly what it would cost them under their health plan, as well as the average cost.
Under the next segment of this plan is we want the patients to begin the process of getting care through a patient-centered medical home, and then when they're referred to other doctors and hospitals, that they would be referred to the most efficient and effective clinicians available to them in their community. Under our Get Better Maine website, this is an example of how we would be looking at how well a doctor performs. Is, do they provide the care that experts recommend? Do they provide it safely? Are patients happy with the treatment that they get, and is that care provided at a reasonable cost? And so we want, under this plan, to utilize the doctors who perform best under these 4 categories to be the lead doctors in providing the benefits. And then we recognize for doctors to change the way they practice and to spend more time helping patients evaluate their options and perhaps hook them into other resources in the community that can help them take better care of themselves or better self-manage their condition. It's going to take time. And so we believe under this program is we have to change up the way we reimburse doctors too. So those doctors who are effective and efficient, instead of losing money because they're seeing patients or arresting conditions earlier on, that they get paid less, we actually want to pay those doctors more. And we want to do it in a number of different ways. one of which would be something like an ACO arrangement or an alternative quality contract that helps the clinicians who are helping us provide care at a more reasonable cost to get a share of the savings. Now, what's interesting under this program is we do believe, however, that it's also going to be a change for clinicians, for patients. It's going to be a change for health plans, too. So we also think that the savings should be parsed out appropriately to all the organizations who help make this happen, including the patients, so that over time we're hoping that this VBID plan is going to become more and more affordable for patients. So now let's go back to the idea of this being a fishbone diagram and look at number 4. Under number 4, we thought, okay, we've got the benefits set up so that we encourage high-quality providers, high-quality services, highly efficient, effective services. We are discouraging the use of services that have the least amount of evidence. We're restructuring things to give clinicians and their staff the time to help patients self-manage more effectively, and the patient walks out of the office and doesn't do any of the things that have been recommended for them. And so the fourth piece of this program is designed to say, how can we help, how can the plan design help support the patient to do the right thing, and what are the carrots and the sticks that have to be in place for the patient to get on board, but also what has to be happening in the community to help the patient be supported in making the changes that they need to make. And doing this work inside the Maine Health Management Coalition through the generosity of the state innovation model, we have another group called the VBID Wellness Committee, and that Wellness Committee is actually working on 2 different things. One is, again, what are the right benefit design features that have to be in place to support wellness, but also what kind of programs need to be in the community. And they're looking at some really interesting, innovative programs that are in place. And they recognize that a shift in health will only come about if we take some of the bigger issues like social, environmental, and economic systems that influence our health and health behaviors and health choices in place and look at how to solve this on a community collective level. And so we have been starting to think, what if we start to combine our wellness efforts and make that, instead of one insurance plan having certain wellness programs, and an employer having certain wellness programs, and a community having wellness programs, and hospitals responding to their requirements under the IRS and the Affordable Care Act, and have another set of services. What if we started to pool our resources together and started to say, let's look at what we can work on in the community, but let's look at first those services or those efforts that are evidence-based that can have a significant return on investment in terms of reducing our overall costs. So an example of that might be, we know that each of our communities in the state have an issue with preterm birth. We know they can't all be avoided, but we believe some can be avoided. And we know there are successful programs that are designed to prevent preterm birth. What if we, took our joint funds and started to work on a program like the Nurse Partnership Program that could help us prevent preterm birth? Suddenly, we would have millions that we are saving the overall healthcare system that could be shared back with the participants that helped make that happen and bring down the cost of healthcare, but also help us have more funds to start to work on more wellness efforts. So they're looking at social impact bonds. They're looking at setting up something like they've done in Massachusetts and are considering in other states called Wellness Trust. And so we're doing a lot of innovative work to try and figure out, can we do more in wellness if we work collectively together? And if you're interested in this topic, we invite you to join the VBID Wellness Committee. So the next thing that we realized that we had to take a look at, and that the IOM had told us is a place where we're spending money that we probably could eliminate spending, that certainly wouldn't impact any of the benefits that we are providing, and that is the administrative cost of seeking reimbursement under a health plan system. And I've seen studies that have shown that up to 10% of a hospital bill is the cost of a hospital seeking reimbursement for those services. And I've seen other studies that say the average practice in America spends $86,000 per doctor per practice. So each doctor at each practice is spending about $86,000 a year, again, just on administrative work connected to reimbursement. So we said, gee, can we start to take a look at this? And the health plans in Maine really came up to the plate, provided us with a list of the top 10 complaints that they get from both providers and from members, and we started to take a look at that and say, what kind of issues can we solve? And Robin Allen has been working with the VBID Administrative Committee, and they are one of the first things they're looking at is, can we standardize the credentialing process? It's not uncommon for a practice in the state of Maine to go through 23 entities to credential a doctor and to answer the same questions over and over again. So we're looking at, can we have set up a system so the practices enter the information once, and the 23 entities who want that information, their questions are answered in this one form, and then they go in and they get the information, and we move the process along faster and eliminate all the efforts that go into having that system repeated 23 times. So again, this is another committee on the program. We are also having the administrative committee look at the benefits, very much like I explained the colon cancer screening. Does this make sense? Where does it fall apart administratively? So that we can start to adjust this so that we eliminate some of the unseen costs of people at the pharmacy calling back to have doctors change up the prescription, or having the patient have to check back in with the insurance company, or change what's being offered because the rules are different for each plan. What we're hoping will happen as a result of this VBID plan is that we will come up with one standard plan design where all the benefits are exactly the same. The information about those services would be put into an electronic medical record, and that we would get feeds from the insurance companies that will help the clinicians to be able to tell patients exactly how they're covered under the plan, where their spending is at the deductible. In a really wonderful world, we could even tell them how much money they have left in their health care savings account they could dip into to pay for services that are not, that may fall into the red category, but that we can give this information to clinicians, and that the rules will be two practices, and that the rules will be the same, so that at some point in time a practice can decide to say, look, I take all health plans, but I only take the VBID plan, and they will start to know that the rules are always the same for each and every patient, even though the benefits are clinically nuanced. So right now, we do have great support from clinicians in the state of Maine on this project, brokers, and the health plans. And what we are doing is we will be publishing information about the health plans in the state of Maine. So like patients who go to Get Better Maine to pick a doctor, those plan sponsors in the state of Maine can go to our website and see how close, health plans come to offering that standard plan. And so you may be thinking at this point, boy, this is a big idea, and it seems a little communistic that we're all working together, but we think that there's a lot of value in us starting to standardize, and we think that the time is right now. And we think because we have the Maine Health Management Coalition database that is on track to provide information about 92% of the claims that are incurred in the state of Maine, that we will have data that we can use to track this. We also think that if we can start to standardize this plan, we can enable practices to change over to these new outcome-based performance mechanisms, because they'll have more patients who are in that same plan, and they will have the mass that they need to change, will have the data to be a neutral arbitrator, and that they will start to be able to save money through the standardization of the operating rules and quality measurement. And we think because we are doing this on a state basis, we will become attractive to other organizations like electronic medical record vendors, who will see that it makes sense for us to build an electronic medical record that can publish this information for use by doctors, for patients to see in their portal, that grantors would be very interested, that public payers would realize that we have already built a framework that they could try new innovations on too, and that Maine could be a potential place to test out this model, and that we will eventually have an opportunity to attract and maintain more primary care physicians. And I want to make a point or emphasize a point at this juncture is we just got finished with 2 days of focus groups with patients around the state to test out what do they think of this value-based insurance design. And you would maybe be surprised, maybe not be surprised, when we asked the patients what did they think of, what their doctors would think of this plan. So many patients began their comments by saying, well, I know the doctors don't like the way the plan works now. And almost everybody told us how dismayed and disheartened their doctors are by the current system of supplying health benefits to patients, how enormous the workload is in terms of administration, how the benefits don't seem to make sense. And so we think that by starting to standardize and making these standard options available, that we will start to make things easier for practices to operate. And if we make things easier for clinicians to operate, we are certainly in a better situation should anything terrible happen to us in the state of Maine, an epidemic, a terrible, accident that happens, or a terrible event, and many of us have to go into the hospital systems or into doctor's office. The more streamlined this is, the more that our doctors and clinicians can concentrate on taking care of health issues instead of having to worry about all this administrative work. So I just want to share with you how many people in the state of Maine have already started to help us build this plan, and also invite you to join us if you would like to participate. We have found that having more people in the room gives us many more angles, many more views from the elephant, and it makes us a richer, better product. And so please, contact Robin Allen or any of us in the Maine Health Management Coalition, and we can hook you up and let you know about meetings. But we are finding that it's been extremely helpful, and it might be interesting to note that there aren't people just from Maine anymore who are participating in the work groups or helping us on this project. people from all over the country are starting to participate. We are in contact with people in other states who are doing somewhat similar things, and they are very interested in what we are doing. And we also understand that the more standard this is across payers, the easier it is for the payers to implement. And so we are now starting to work with more and more organizations who are working in their state or have a national vantage point to work together so that we can make this easier for everybody to participate.
Okay, everybody, I hope you enjoyed Nancy's presentation, and I do encourage you to type any questions you have in the chat box. I do have a few questions that I will read out loud for everybody, for Nancy to answer, and you can go ahead and type your question at any time. Nancy, one question we have is, how soon do you expect this plan to be available?
We are working to have this plan designed by the end of this year. We have started to work with electronic medical record vendors about how could we take this plan design and make this information available to practices. But we also know that there is a large employer in the Portland area who has many unions, and their unions are going to do a very close or the first generation of value-based insurance design effective January 1 of 2016. So there is at least one group who is already slated to offer a plan that's very similar to this on January of 2016.
Thank you. Okay, another question here. Do you think it is reasonable for health plans to develop this plan just for the state of Maine?
As somebody who worked in a health plan for 15 years through 3 different health plan programs, I know that it could be very difficult to do a one-off plan. Even though they offer one-off plans all the time, this is exactly what we're trying to start to scale back a little bit, because it causes a ton of confusion inside of offices and even among patients. And it's, again, something that we picked up in focus groups is people told us, well, I had an Anthem plan or an Aetna plan, and I switched over and I thought I was getting pretty much the same thing, but it was different and I was all confused. We're not saying that this plan design will take away choice. What we are saying is that this would be a standard plan. And we understand, however, that building even a new plan is going to be work. So what we're doing under this project is we are building both the summary plan description of the plan, so all the rules of the contract in which states how the plans are covered. We would also be providing the codes, and so we are trying to help the health plans make it easier, but by reaching out to other states, and we are now working with people in Maryland, Connecticut. We just found a group out in California who has Medicare as one of their participants, who is trying to work on a national level to build a standardized plan. So we are trying to connect with as many states as possible so that it will make it easier for health plans to administer these plans and to standardize things, because we believe that standardization is a key to quality.
All right, another question for you, Nancy. How will you coordinate the different EHRs that are used by various provider networks and ACOs?
Well, what we are doing is we've reached out to the EMR vendors who are in the area where we know the first VBID plan members will be, and we're starting to work with them to incorporate this. But we are working with them one-on-one.